So I'm Dr. Barbara Ariue. I'm one of the pediatric allergy immunologists at Loma Linda Children's Hospital. And I'm actually part of the SAMPRO committee for the Quad AI. I'm also on the asthma committee of the American Academy of Allergy, Asthma, and Immunology, the American College of Allergy, Asthma, and Immunology. I'm their asthma advisor. I'm also on the Diversity, Equity, and Inclusion Committee for the Quad AI, and also the past president of California Society of Allergy, Asthma, and Immunology. So I'm here to present the SAMPRO, and so this is a school-based allergy, asthma, and anaphylaxis management program. And so what are our learning objectives? They are to introduce you to the SAMPRO, which is the again, the school-based allergy, asthma, anaphylaxis program. Previously it was just asthma, but it does include the three A's. And also we have to be more aware of health inequities in asthma and allergy. And also we want to implement our national guidelines for asthma. If we do that, we do see better outcomes. And also we want to introduce you to SAMPRO. And these are some main things of building this circle of support, which you are all part of. And also we want to develop a shared asthma action plan, as well as a shared allergy and anaphylaxis plan with our students. And we wanted to have this comprehensive way to have educational programs, which you're just seeing here as well. And we want to empower our schools to employ also environmental assessments to help mitigate asthma triggers. And we want to fulfill the SAMPRO goals. And those are things like stock inhalers and stock epinephrine. So what is new? This SAMPRO came out a few years ago, but there are some new things. They incorporate food allergy and anaphylaxis. And we also want to talk about health disparities and also updated asthma guidelines. And also the stock inhaler toolkits are from the Quad AI, the American Academy of Allergy, Asthma, and Immunology. And also there's been technology advances as well. So schools and asthma. Why is this so important? As you all are aware as teachers, asthma does affect 4 million children. That's about 6% overall. And asthma is a leading cause of school absenteeism. And also we can see that children have more like 10 million missed school days. And when you have missed school days, that's also parents are missing work days too. And then the main thing too is that if you have absenteeism, then children may not do as well in school if they're absent from school. And that means teachers, they won't be able to have that teaching. And also, what is some of the barriers for comprehensive asthma management? There's a lack of communication with students, parents, teachers, nurses, and also providers. And even between providers, I'm a subspecialist, but also we have primary care doctors. There's a lot of not communication here. And also there's continual exposures in our schools. Children spend a long time in school. And my colleague in Boston found out that there was problems with that. They're mainly in school and they're having these bad exposures. And also we may have a lack of full-time nurse. And also school nurses may not be aware of the doctors, what we're doing for like our asthma management plans. Like, I may not communicate as well with our school nurses. And also clinicians such as myself and also others may not be as aware of all the updated asthma guidelines that come about. So there are health inequities in asthma, and these are some things that are kind of stark. African American children, this is very concerning, have a 4.5 times higher ER visit rate, and look at amount of death rate, 7 times higher. And also you can see for the African American adults, it's a little bit less, but the Hispanic children too have a very high ER visits, and that's compared to Caucasian children, and then 2 times higher death rate. And the Native Americans are more likely to have asthma, and again, they have a higher related death rate of 20%. Minority children are less likely to use their daily asthma medicines, and we're talking about preventative controller medicines, not the short-acting ones. And Puerto Ricans also have a higher rate of asthma as well. So there are some concerns for health inequities. How do we manage to reduce these asthma disparities? Well, one is about to identify those patients who have asthma, and I think it's very good about how do we identify these patients? And then the other part is how do we offer some personalized, culturally appropriate, wording, as well as maybe in their own language. And I'm also big about also pictures and making sure we know what we're talking about. And a big one too is for specialists, it's very important that I hopefully teach our next generation, such as we have a lot of residents in our medical center, and we also have, residents, we have fellows in training, so we need to educate our primary care providers about current asthma guidelines, because if we're following asthma guidelines, we have better health outcomes. And also schools, this is where we're talking to you, and I was so happy to be here, is that schools are actually a viable way to help with racial disparities. So we can provide, really good help in those inequities here in our schools. So what are these 4 components? That's establishing the circle of support. It's developing a shared asthma action plan and a shared allergy action plan. And we want to develop a comprehensive educational program. And I think my previous speaker was very good about talking about the educational part too. And we want to empower our schools to help decrease environmental triggers and also strategies to reduce these triggers in the environment. So what is this first component? It's establishing the circle of support. And here is this picture, you have the school nurse, okay? And then our clinicians and also the family. And we want to have good communication with all of us. In the background is, of course, the community, and in the middle is the child. So we want to establish the circle of support. Establishing the circle of support is very important. Each member, whether it's a parent, the family, the school nurse, also the clinician, it's all very important. Asthma action plans help us to communicate very well, and we want to strongly recommend employment of our full-time nurse or healthcare provider or healthcare team. Clinicians should be aware that a school nurse may not always be available, so I think we're kind of aware that, she said, how many students do you have?
9,000.
And so she may not be at every school each single time. So we want to teach our students about being able to do, emergency self-management, and also easy access to visual teaching is also really important. So we have this circle of support, the checklist of, like the asthma action plans, the supplementary treatment orders. We also have essential features of the asthma action plan. The school nurse has a checklist, and also the family as well has a checklist too. The other things, the big ones that we want to talk about are the asthma action plans in schools. And what is part of the standardized asthma action plan? It involves the family, the school nurse, and also the healthcare provider. And we want to talk about these medicines. There's a difference between maintenance daily medicines as prevention, and also the fast-acting bronchodilator, we call fast-acting beta agonist. And also we have standard asthma action plans that are essential. And we want to know the right medicine for the right patient. And we now talk about what we call inhaled corticosteroid for Moderol, which is part of maintenance and rescue therapy, which are part of our new asthma guidelines that we want to introduce you to, and make sure that you're aware of maybe something called Symbicort, Dulera, or Breyna now. And we want to be able to correctly have them know how to use their chamber device. The Sampro allergen asthma management plans are also very important. These are the asthma action plan, and also, as we told you, allergen anaphylaxis emergency action plan as well. This is asthma action plan, and then it's broken down into this here area. You will want to identify the asthma severity. I think a lot of the practitioners sometimes will just write asthma in a child, and in fact, even in our documentation when when we're in the hospital, I see sometimes these asthma in a child. We got to identify mild, moderate, or severe. Is very important. We also there's a check mark here for recurrent exacerbations, so that child that's having a lot of exacerbations, attacks, we want to be aware of them. And then also prophylactic, we call fast-acting beta agonists. Before exercise, we use a fast-acting or rescue medicine, and it may be different now that we're talking about new asthma guidelines. And the stoplight, green, go, means that when the child is doing well, they'll continue taking their preventative asthma medicines. But we also have here, continuation of the asthma action plan has the yellow zone area. Again, the stoplight, yellow, caution. So they might be having some symptoms, but not, they can maybe do some of their activities, but not fully all of them. And then also the red zone, where they're not able to do most of their activities and you need to call 911. The triggers are also, should be identified as well, and we want to educate our patients about avoiding these triggers. Their medicines, contact information is there, parental release of medical information, and the nurse acknowledgement as well. This is also part of the school supplementary treatment orders, and what this has is clearly designates asthma rescue medicine. So what the patient will have at school for rescue, and that has changed. Our new asthma guidelines are very different now. So we don't just use albuterol. We may use a more pure form of albuterol called levoalbuterol. That's not the big deal. It's the ICS formoterol. So that is, ICS is inhaled corticosteroid with formoterol. That is Symbicort. It's also Brena as well. The other one as well is Dulera. So we got to know about these other names of fast-acting beta agonists, because they may bring those to you as a teacher and also as a school nurse, and those are the ones they're using for rescue. And also the controller medicines are the ones that are using as a daily basis to prevent their asthma. And most of the patients, we tell them usually to keep those ones at home. But as you'll later find out, they can be the same medicines for rescue. This is also the school supplementary treatment order that delineates asthma triggers, identifies asthma severity, and also has the signatures as well. So we want to introduce you to the National Asthma Education and Prevention Program, which is our NAEPP. This is our national guidelines for asthma. And we also have GINA, the Global Initiative for Asthma. These are our standards of care for asthma. Globally, this is a strategy. It's not our guidelines. It's for many local nations to follow, and it is updated yearly. There's some differences between what we call GINA, the Global Initiatives, and the NAEPP. The composition of the experts are different, and also the scope of what's in the documents are slightly different. And also emerging topics are different. And one is a global strategy, the GINA, and one is our national guidelines. Again, the scope or what is in it is different. Again, the GINA is comprehensive, it's a long document, but it's updated yearly. So we get more updated information. And also we have different age categories, a more fluid approach on the GINA, and more of a stepwise approach on the NAEPP, our national guideline. So this was a big deal for the asthma community, that in GINA, the Global Initiatives of Health, they said in 2019, regular use of albuterol is not good. It led to increased hyperreactivity and more exacerbations and even mortality. Those are asthma deaths. So we want to think about that short-acting beta agonists alone might train our patients to just rely on that. And that's another reason why nebulizers are not as recommended, It teaches them to rely on the albuterol. We want to teach them to rely on a alternative. A safe alternative is inhaled steroid and formoterol, and that was a big deal in 2019. So you may be seeing not just albuterol bringing it into the school, you might see Symbicort, Dulera, or Breyna coming into the school. Go ahead.
So if they were being given the steroid or the Symbicort and things, would they also still have albuterol if it's being used as long-acting and short-acting? So
we would tell you that actually this was a big deal. It became, yes, we do use Symbicort as a daily and as needed medicine. That's the inhaled steroid, and the long-acting beta agonist formoterol can be used as a daily or as needed medicine. So it was kind of a big deal in the asthma community. And this were some of the studies, there's a lot of studies, but the main thing is you can see this favoritism of, you see that FABA, that's a fast-acting beta agonist, that is a formoterol, and the inhaled corticosteroid combination. You can see that favoritism, meaning that that's the better way to do things versus just the albuterol or the fast-acting by itself. And you can see a reduction in asthma exacerbations with that, as well as less ER visits and hospitalizations. So yes, we can use something like ICS formoterol, which is Symbicort, Dulera, as well as Breyna. We can use it as a daily maintenance, and we could also use it as a rescue. So we want to make sure that school nurses are well aware of that, and also that even teachers may be aware of that. And then this is some of the things that we always, when we're seeing patients, we're always reviewing whether or not they're actually taking the medicine, which is a big deal. Many times, no matter how many times we tell them that we should be taking them daily, many times they just don't. And even they tell us they're taking it daily, and I'm able to see on my computer system, oh, are they really filling it at their local pharmacy or not? And I could tell that, oh, they're not filling it. So many times, unfortunately, adherence is not good. They say adherence is not good. And also, inhaler technique is often not good. More than 60% of patients don't use their inhaler correctly. And then also, environmental control is also important. And then as well as comorbid conditions such as allergy, what we call allergy nose, allergic rhinitis, also obesity, and things like obstructive sleep apnea and things like that are very important.
So with inhaler technique, do you prefer the spacer to be used instead of the straight inhaler?
Oh, most definitely. So we definitely think that everyone does need to use it with a chamber. They may no longer need a mask, but they definitely need a chamber device. We could see if they don't use it with chamber, that most of the medicine hits the back of their throat, goes into their esophagus, and then goes into their stomach, and then we'll see more side effects, increased heart rate, thrush, we call overgrowth of bacteria, fungus in the mouth. But when we use it with a chamber, more of the medicine gets inhaled to our lungs, but we have to show them how to do it correctly. So it's very important that they do use it correctly.
Do you have a magical way of getting insurance to pay for another chamber?
I don't think I have any magical way. However, I know that a lot of my patients, we have different types of patients, and then we do know that our patients with the Inland Empire Health Plan, which is our managed Medi-Cal plan, which probably a lot of your patients or students might have, we do know that for our patients, they will cover one chamber per year, but they'll also let us prior authorize a second chamber if we do a prior authorization. So many times my school-age children, I'm often telling the parents, well, I'm gonna send one to your pharmacy, and then the second one, I'm actually gonna prior authorize the second one, so it might be a few weeks, but check back at your local pharmacy, and then most likely our prior authorization should go through. I'm also at the Riverside University Hospital System, and actually we do have chambers there to give out to our patients as part of they had an asthma grant from the American Lung Association. So we're able to give out free chambers to the children that I see in subspecialty care. I represent allergy and pulmonary there, so we are able to give them out free there.
What about the steroids, inhaled steroids?
That's right.
Do you just recommend it straight inhalation from the actual cartridge, like Wixella or Brina or
That's right.
Symbicort?
So Symbicort and Brina are meter dose inhaler. They're
Okay.
pressurized meter dose inhalers. Those need to be used with a chamber device.
Okay.
And then things like dry powder inhalers, like Wixella, and also we have other things like FlexHaler, DigiHalers. Those are dry powdered inhalers, and those don't use a chamber device. But the ones that we're talking about, ICS for Moderol, which are Symbicort, Dulera, and also Brina, they are pressurized inhalers that do need a chamber device.
How do you spell Brina?
Brina is spelled Breyna, and then we do, over here, we have some we have this poster and all that, so we'll go over that, because I think many times, a lot of my patients, they go, I'm on the orange one, and I go, which one is the orange one? Or I'm on the blue one, which one is that, right? So this is MART therapy, and this is all the rage for our asthma, our asthma community. And what this is, it's called SMART, and they also get smart, right? Go ahead.
I just had a question real quick as far as prescriptions, because I'm having parents, some will come with the 2 packs of inhalers.
That's right.
Some will only come with 1, and they don't want to leave an extra one in the health office if their child's self-caring. Is there a key to tell the parent when they go to get a prescription that has 2 boxes for inhalers? What do they
So usually they should, like for regular albuterol, it's not, it's typically most insurance can cover 2 versus 1 about the same way. The only hard part with the MART therapy is that many insurance may not cover 2 ICS for Moderol at a time. They're used to covering it just as a maintenance, but new guideline therapy tells us that we can use it as a daily and as a rescue. But the main thing is that the provider can ask for 2 at one time, and usually we like for one to be, if the patient carries it, they may just need to have 1 to carry it on person. If there's if they're young, we usually tell them that if they're very young, we do want it in the office and they need help. So typically when they're under 12, when they're in the elementary school side, or if they have disabilities, they may need help.
Yeah, in our district for self-carry, we ask if they have a second one in the office, because
Okay.
there's times where they forget.
That's
and
right.
We don't want them to be without.
That's right.
And I have parents saying, well, I can't get another one, and
They should be able to, ask their provider, is what we would say. We usually are able to write for 2 at a time. The only one, again, is this MART therapy that is a little bit different, because this one is typically it's a maintenance one, FDA approved for maintenance, so that's the only kind of hard part. But MART is the maintenance and rescue put into 1 inhaler. And then that one is a little bit harder to get as 2 in a month. But we're working on it.
we need them for school.
Yeah. And this is some of our guideline care. Again, this is GINA for 12 and above. This is the recommendation of what they should be on. So the top category is what they really should be doing. They should be doing a low dose maintenance called ICS for Moderol, and then also as an as needed as well. And then you can see at all levels across the board, it's that reliever is ICS for Moderol, not albuterol. Okay, you can go down to the less preferred down below, which does have the albuterol down there, but again, preferred is just doing ICS for Moderol by itself as a rescue and also as a maintenance. This is the NAEPP, which is our U.S. guideline therapy care, and it's a lot of wording there, but again, 3 and 4 are again MART therapy, meaning ICS for Moderol and ICS for Moderol as needed. That is preferred treatment now, standardized for our asthmatic patients and globally as well. And then this is for 6 to 11. It's a little bit different, but again, you can see for GINA, again, this fluid thing that we as providers should be assessing, adjusting therapy, and also reviewing technique, things like that, comorbidities. And we should then not just give a higher dose of medicine, but we should be asking them, like, is there any comorbidities? Are they really using their inhaler and spacer correctly? But we do have this assess, adjust, review circle there. Again, 5 to 11, again, step therapy for the national guidelines. 3 and 4, again, is the maintenance and rescue therapy. that is new, okay? And then also, again, the choice of inhaler. This is a single maintenance and rescue therapy, which is SMART. This is very important for asthma, and it is now approved in our national guidelines all the way down to 4. So that means school-age kids will be taking if they're going, according to for those are for the moderate to severe patients. And then you have for the global initiatives of health, it's for over 6 years old. And, but the implementation for SMART is not quite there. There's not FDA approval for ICS, for Moderol to be used like that. And also, but it does allow us to use 2 medicines in one, and allows us to titrate the inhaled steroid and the long-acting beta agonist. And we do have a maximum dose for the older kids of 12 puffs versus 8 puffs in the younger children. And then this is our respiratory treatment poster, and this is from the Allergy and Anaphylaxis Network. And I think that QR code at least takes you to the Allergy and Asthma Network. And whenever the children are in the office, I like to make sure we're all on the same page. Like, what medicine are you doing? And actually, you're able to bring it up on your smartphone. So that if you really need to know which medicine, sometimes hopefully a picture is better than wording sometimes, what medicine are they really taking? They'll often tell me they're on the blue inhaler, the red inhaler, and as I tell them, these medicines here are all albuterol, and so, this is all albuterol, kind of like from here until here are all albuterol. So they all look different, they're different colors, but they're all albuterol. So we want to make a notice of not just the brand name, but the trade name. And as you can see, Breyna is down here in that in this kind of green. Yeah, let me see if I can. Yeah, let's see. So Breyna is that green and blue one. I don't know what this point as well, but Breyna is a blue and green one, and Symbicort is that red one there in the middle. And actually, they're the same medicine. So they're both inhaled they're both budesonide for Moderol. They're on that kind of middle line with the combination therapy, but Breyna and Symbicort are same medicine. And again, Dulera is the blue one in the middle, but those are the 3 that we use for what we call MART therapy. So you may be seeing not just the albuterol and the Xopenex coming in, you may be seeing the Symbicort and also the Breyna and also the Dulera coming in. And how to use our inhaler and spacer correctly. So it's very important that we use it correctly. On that QR code is the American Lung Association, and it has other of how to use other inhalers, whether it's the dry powder inhalers or the inhalers there. And actually, last week I was actually I was trying to teach one of my patients how to use their inhaler and chamber correctly. And we were going over that for most of the kids like under 12, then we'll usually try to tell them that a lot of them will use will use a mask. When they get older, they don't need the mask. And then so I was trying to tell them that, we shake our inhaler, put it into the chamber device, put the mask over the nose and mouth, spray once. And then this is rebreathing because it's a mask. Then we have them rebreathe in and out 6 times. And we want to keep the head level, okay? And it's a slow, deep inhalation that we want to train them to do that. Then we take the whole thing off, wait a minute, and then we do it again. Okay, we don't do 2 at a time. And then my patient told me, no, I was told by our nurse that you don't do it that way, doctor. You just take 1 deep breath in. And I go, that's right, but that's not but for the spacer with the mask. So the mask, you actually have a rebreathing, okay? And so for the younger kids, we often like to use the one with the mask. For the older kids, and usually 10 and above, they may not need to have a mask. Then they can do it with just 1 breath like that. Then we tell them shake the inhaler, put it into the chamber device, breathe out, put your mouth on the mouthpiece, spray once, and then breathe in. And sorry, I'm not gonna put my mouth on here because it's not quite mine, and then we'll breathe in. And hold. Okay, and my mouth would normally be on the mouthpiece, okay? And then we take it off, we wait a minute, and then we do it again. So my patient tried to tell me, no doctor, that's not the way you do it. My nurse told me that you just do it one breath and hold your breath for 6 seconds. I go, that's correct if you're if you're a big kid and you're doing it without the mask, okay? So differences, okay? And then, so again, correct technique is really important for our patients. And the choice of an inhaler is also important, not only for our patients, but also the environment. So we're also here to tell you that, as you can see, there's a lot of different inhalers. We have some samples there. And the choice of inhaler is very important. The dry powder inhalers don't use the chamber, okay? And they are suitable for children, they need to be over 5. The reason is, if you have a dry powder, you have to be able to breathe in and have a good inspiratory flow. Okay, and little children under 5 typically can't do that. And also those with disabilities may not be able to do that. And also, those that have weak muscles may not be able to do dry powder inhalers. And then we also have some that have a little capsule. They can't do that if they have a shaky tremor hand. So when hopefully the doctor is prescribing the right inhaler for your patients, okay, and your students. And it's very important when we talk about MART therapy, just using one inhaler both for rescue and maintenance. Just think about this: if you just have one inhaler, you can maybe teach them how to do that one inhaler correctly. But if you have two different ones, they may do one correctly, but maybe not the other one correctly. And if you don't know how to do your thing correctly, it's going to lead to more symptoms, worse adherence, and also more exacerbations, which we don't want. And also thinking about propellants. So unfortunately, the pressurized, we call pressurized, and MDI's metered dose inhaler, these lead to global warming. So that's why the dry powder inhalers are more, if we can have them do it, if they're able to do it, then we have them do that. That's why the choice of inhaler does make a difference. And this part, again, we have the standardized allergy and anaphylaxis management plan. So we also not only do asthma for the allergists and pediatric allergy and immunologists do asthma, and we also do anaphylaxis. So we're usually the ones doing all your school notes. I do epinephrine, Benadryl, I do Neffy, I do all that. So guess what? We also have school tools for anaphylaxis and food allergy, and we also have management plans for them. And also we want to provide the same kind of circle of support for both our food allergy patients, and we also want to make sure that we want to minimize their risk of having those foods at school. And the reason is that if they have food allergy and asthma, which many patients do, if they have food allergy and they have asthma, they're at higher risk of a more severe exacerbation or attack if they accidentally get into their food. So it's really important when I see my food allergy and I see for food allergy that we're actually controlling their asthma as best as we can. And in fact, here's a sample of our anaphylaxis emergency action plan. It's individualized, it identifies which food they have problems with, or allergy. It could be like bee sting, other things as well. We want to characterize the symptoms of anaphylaxis, and those are the symptoms of anaphylaxis. And we want to also provide emergency action steps, and it also specifies epinephrine dose and bread. We're not updated though, because now we got Neffy. So there is AviQ, epinephrine, all other things, but also Neffy as well. It should be on there.
Is Neffy covered by insurance now?
Yes, it is. So it is FDA approved, and so I just met with the makers of Neffy. They're actually the same makers of Narcan, Dr. Tanimoto, and then so from ARS Pharmaceuticals, and just recently they launched. So I was at the American College of Allergy, Asthma, and Immunology meeting in Boston, Massachusetts, and it is FDA approved.
So is it true that when they order Neffy, that they also order an EpiPen?
No, so if we
Because I
have.
was reading some article on that.
No, so if you have, it does work well, so it's not like you would order Neffy and you have to have a backup epinephrine IM. No, you would just have Neffy by itself. So, and there's multiple studies showing the efficacy of the nasal epinephrine, the same way as Narcan. Do you have an IM Narcan somewhere around? You guys are all very well of Narcan and might have had even Narcan training. Do you have another way to give Narcan? No, you have just a nasal spray, right? So it's effective, and we could show that it does enter the bloodstream well. It is effective dosing, and the same way that you use your Narcan, it's the same makers are doing the epinephrine nasal Neffy. So there's not need for backup epinephrine IM.
Do you know, does Neffy, is it a longer shelf life than, because epinephrine was not a very long shelf life?
Typically, most epinephrine is about, for the injectable, is about 1 year, depending on when the patient gets it off the shelf. But most of them are about 1 year. Neffy is about the same, but some of the things, it's a more heat stable. So it could go into like 120-degree car and be okay. And it's also better in terms of freezer. So, you know, we're more like, we gotta be aware of the heat part, but other parts of the country are concerned about the cold, like if it's, you know, if it freezes, then they can't inject their medicine, and then, you know, you can't use your injectable epinephrine. But for Neffy, it's better able to withstand cold temperatures, freezing, and it's also better able to withstand heat as well.
And are those dispensed in a 2-pack?
It does usually come as a 2-pack, but only one-time use. One spray to the nostril.
A lot of us get our stock epinephrine through the EpiPen for Schools program. Has there been any talk about if Neffy will ever be free to schools?
I don't, as of for right now, we're not, you know, but that is something that I'm talking to Dr. Tanimoto there, that you gotta follow the Narcan, you know, and follow, and also if it could be, and I'm also really a proponent of making sure ICS formoterol is in our school, not just the albuterol, because that's the way that it is going in terms of guideline therapy. So hopefully Neffy, hopefully maybe ICS formoterol will also come about. And, you know, so this one is, these are some education for our nursing and for our staff is really, really important. And the Asthma and Allergy and Anaphylaxis, you know, network does have this. And then again, it's not only, it's the school nurse, and as she just pointed out, the PE teachers and also the students. So educational resources are also very important. We have here, you know, some of the educational resources for school nurses, this part of what is asthma, and the big one is, again, how to use your inhaler. So hopefully, you know, if everyone knows how to use their inhaler correctly, that would be really good. And then that one is as a video. And PE teachers, like you were saying, it is so important that PE teachers are also well aware of activity in the schools, treatments, and also interactive maps, and also, again, how to use your inhaler is important. And then here for the students, it's also different. There are some programs for students on, you know, knowing more about asthma, and it's also there's some age appropriateness there, some for middle school and some for 7 to 12-year-olds. And this part about environmental asthma plan, assessment, remediation, triggers in the school, what are we doing about that? And as you're well aware, during COVID, wow, wasn't that needed, right? So during COVID, I mean, that was 4 years ago, but so helpful about knowing about health and hygiene, ventilation, air cleaners, cleaning the schools and disinfecting. And the indoor air quality is really important for the children with asthma. So, you know, children are exposed to these air pollutants. They spend so many hours in school, and many concerns of things like classroom pets, dander, dust mite, mold, fungus. And in Boston, a big concern was actually, do you know which one of these things were a big concern of the indoor allergens? Cockroaches? Yeah, that's what I thought. That's what I thought it would be. It was mice. It was mice. So they found that the big culprit was mice. I actually thought too, I thought they would find cockroach, but they actually found mice. So once they were able to identify that, they were able to have some remediation. But mice are a big deal in Boston, maybe too here in Southern California. Also, students are exposed to school-based air pollutants as well. And unfortunately, children living in inner city and impoverished neighborhoods, these are the children disproportionately affected by more hazardous environmental problems. And these are some indoor air quality management programs, like you can have a walkthrough, and also you can also identify those environmental exposures in the school. And then these are some resources for our custodial staff. And how about wildfires? Weren't we all affected by the wildfires back in September, right? And unfortunately, you know, they think that 56,000 wildfires, and that's what we saw here in Southern California. I know my children's school, a whole week of school, they were off being close to Loma Linda area. And then we actually live closer to a fire as well. And it's projected to increase by 50%. It's really important for our patients and the parents to understand and minimize, you know, their wildfire exposure, and also for schools and their households as well. So we got to know about the air quality index and be aware of that. Is very important. We could follow the wildfire forecast as well. And what else? Ways to reduce these smoke exposures. We want to know about the air quality index. So if there's, you know, if there's bad air quality, we want to reduce their exposure and maybe not have them do their PE, or be aware of that. Also, we're well aware of like masking as well, cleaning and improving the air quality in the schools by using like HEPA air filters. And then also avoiding like burning candles and incense, wood burning stoves, furnaces, and also spraying aerosols. I've had a few patients tell me that in the classroom they spray some aerosols like to clean the air, but that could be an irritant to our patients who have asthma, and it's not helpful for the air quality. And then also making sure they have their asthma action plan available too.
And then changing the air filters, because like after the wildfires,
That's right.
they went around to all the schools and we had to change them, and I saw some of them and they were
They probably looked probably
terrible. They were
bad.
black.
Yeah,
they were
I
really
believe.
bad.
So we're going to talk about integrating policy, and again, we don't have any, I don't have any, won't say any one way or the other, but you know, it's legislation. We just had our election last night, right? But legislation in asthma is very important. And so, you know, here, this was actually a bipartisan bill that came out both by two representatives, Democrat and Republican. He's the MD Phil Rowe, and it actually enacted the school-based asthma management program. And so what does that say? That students who have asthma or allergy should be assisted and also need to excel in an asthma-friendly environment. This was passed in 2021. And what does it ensure? It ensures that there should be a school nurse or an aide, and also that there should be students with allergies and are identified, which we're glad that you're doing that. And also that they should have an individual action plan and coordinated support system. And of course, you know, our former president signed for Emergency Epinephrine Act. And you can see that there's some differences. Stocking epinephrine. These are the states that have stocked epinephrine, and you can see widespread, you know, enactment of stocking epinephrine in most of the states. They're all blue. Most of them are stocked. But look at here, unfortunately, stocking albuterol in schools, like she was asking me, you know, look at our state, California. Unfortunately, we don't have any enactment of stocking albuterol in California. So that's a concern. And then, but we think that if we could do these stock inhalers, stock epinephrine, these are life-saving, as you know, right? And if the child doesn't have them, especially in children that have asthma disparities, maybe we often find that the children that don't do good with their asthma. They don't give to us, school notes, so we're often making the school notes for them when we see them in the office. We have a lot of parents that bring them in, July to August, but unfortunately, those children that we don't see, that miss their appointments, that, their parents are late for their appointment, then they're always like, do you need a school note for your medicine? But you could also imagine that maybe some students don't even have their medicine at school, so having a stock inhaler can help. And also, there's legislation that does enable the schools to stock inhalers and epinephrine at school. And also, we should train, hopefully our staff. And again, we should also not only stock, hopefully maybe, Neffy comes about, because you all know how to do the Narcan. But also maybe ICS for Moderol, we hope, that is more aligned with asthma guidelines. Disposable chambers, because again, better improvement in getting the medicine to our lung if we're using it with chamber device. And stock inhalers are important health benefit allowing the students to return to class or maybe even saving a life. These are our stock epinephrine toolkits from the Quad AI. And so that is, the toolkits there, and also for stock inhaler as well. And then, how do we accomplish this in the real world? We want to use some health policies and also multi-level programming, interventions, and also we want to make sure that children have, stock medicines, and also asthma action plans. Community support is very much important. So some of the take-home points, the SAMPRO, or the School Asthma Management Program, is widely endorsed, and it coordinates asthma and allergy care among children, the families, clinicians, and also schools as well. And school-based programs can help to implement the updated asthma guidelines. And also school-based asthma management programs are a viable way to help reduce the disparities that we see with asthma and allergy. And it's also important that maybe it can also help implement stock epinephrine and albuterol in our schools. These are some of the endorsements, and you'll see in there the things like the American Academy of Pediatrics, the American Association of School Nurses as well. And these are some of the acknowledgements as well. And then,
I just wanted, sorry, real quick, I'm going to go ahead and put up the new QR code while we do questions, just because the ones that you were given got a little messed up, so those are actually the ones if you are giving the survey, so this will be the one to actually do your survey result. So I'll put it up while, that way everyone has time for questions.
Yeah, it was just a format issue. It just formatted wrong, so that one worked. Sorry.
So my question is, I don't know about everyone else, but we rarely get an asthma action plan. So it sounds awesome in the real world, but in our world, we rarely get one.
wow.
So how do we fix that?
It's, I hope that we're requesting it from the clinician, because I know that for my patients, they usually, the school nurse is asking me to, and then I know that when the patient comes in with their medicine forms, we call it, and also we're doing like food accommodation form, medicine forms. There's also one for asthma action plan.
Right.
And about maybe a third of my patients, they're asking me to fill out the asthma action plan. And then so usually I'm giving that to them. In my office, when I see patients, I will give them our asthma action plan. And also I'm on our staff at our hospital to make a home-based asthma action plan as well.
So, when you say reach out to the clinician, in our world, we have to have a release of information signed by the parent in order for us to reach out to get that. And there's a problem doing that.
That's right. I was wondering that, I know that at least for my patients, they come to me with a blank school medicine.
Yes.
They also come with a asthma action plan. And then that we have to fill out at the start of the year. So it's like an asthma action plan, a food accommodation form I'm always doing, and also the medicines, and they're usually the epinephrine, the antihistamine, and also their fast-acting rescue medicine. So I'm usually doing
What
3.
we get back is usually just the order,
Okay,
but I mean, I don't know about everyone else, but for me, I very rarely see an asthma action.
Or if you get an asthma action plan, sometimes it'll show the peak flow meter, and then the parents don't have a peak flow meter to bring in.
So
and
there's
I
a
think
lot of
sometimes too,
problems
like
with that.
even when I order a peak flow meter, it seems like the parent told me I wasn't able to get it from the pharmacy, or it wasn't covered, or something like that. So I think that sometimes is a real problem, and I know, like at Riverside University Hospital, where I see my specialized patients, we're able to give them peak flow meter, we're able to give them chamber devices and things like that, and then typically I'll send it. We should try, at the start of the year, when they're hopefully filling out all their paperwork, to typically send, those blank asthma action plans, with the medicine notes.
Don't they, cause on our, when they sign for the medication, the parents sign, it's the release of information too. It says,
That's right.
I give you permission to contact the provider, so that gives us
On the
permission
order.
to call them, it's on the
And
actual
I'm
medication
actually being
order.
contacted, because
Yeah.
usually
Yeah.
I will fill out all their, because we, at Loma Linda, Pediatric Allergy Pulmonary Division, our nurses are able to make medicine forms, so if the patient doesn't bring in their form, then we make it for them. And then, so I'll often be making their albuterol, their fast-acting beta agonist, or ICS formoterol, their inhaled, their antihistamine, their epinephrine, so I'm usually always doing like 3 medicines. And then also, I'm always filling out their asthma action plan, and then typically, what happens if I don't, or I'm just doing their medicine forms, the nurse will always call me and say, they'll be getting something saying, you need to fill, also, can you fill out their asthma action plan? And then I'll do that for them.
Or we just fax it too, cause the fax number is on the bottom too for the doctors, so a lot of times we're just faxing the asthma action plan with the student's name on the top and asking them to fill it out, so we get a lot
That's
of them
right.
back that way too.
And I know the cost is a concern, cause I've had several parents say that they have to pay for each form that's filled out.
$50.
But if the school will send it to them, then maybe they don't charge them, so I know that's an issue.
Yeah, we haven't run into that.
Yeah, so I typically will get a big stack, like from July to August, and then I'm just filling it out. And then my nurses, because I do usually asthma action plan on every visit, for my patients, then my nurse is able to help me fill those out too. So I hope in real, in the ideal world, that we wanna get these asthma action plans, food action plan, to every school, and it would be good to see if the more that we have them in the schools, the more better the patients will do.
I have found with the fee that you're talking about, that's usually not the specialty clinics, it's an individual, doctor
Pediatrician.
practice.
It's
Where
That's
they're not
Pfizer.
part of a
It's
bigger
Pfizer.
group, where there's
Oh.
that fee.
Yeah.
Pfizer charges $50 so they print
For the
these out.
form, right,
for the
if you don't
forms.
take their printout, but we'll take.
But we
the
always
printout.
take a printout.
Yeah.
Yeah, and at Loma Linda, we don't charge any, the allergy pulmonary division subspecialists, we don't charge anything, and we
The
do our forms,
The
and all that.
diabetic doctors do, it's $50.
Oh, they do?
Because
At
they,
Loma
Unless
Linda?
if you lose
they
their
print
orders.
out.
I don't think they charge you
From the
initially.
computer.
I don't know
That's
if they
free.
do
Yeah,
at
They
Loma
do,
Linda.
they do.
It's,
at Loma
if you wanna fill out my form, if I want my form,
Right.
we're gonna charge you for that. But if you
use
take
Loma
our
Linda's form,
computer
right.
generated form, there's no charge.
Well, I don't
Typically,
know
at least for
anyone
Loma
that's
Linda,
not
I'm not aware of, definitely not in the allergy pulmonary subdivision. We fill out forms of no charge. We also generate forms with no charge, and I wasn't aware of endocrinology doing that. I'm pretty sure they don't charge.
If you want your forms, they do.
Yeah, if you want your own form, which I don't think anyone does, we all get
Well,
printouts.
take theirs, 'cause it's wonderful.
Yeah, it's better than ours.
Yeah, we don't charge an allergy pulmonary side.
I have kind of a twofold question.
Go ahead.
I still am seeing orders that say albuterol 1 puff.
Yeah.
Is that, am I accepting that? Because now I hear the hospitals are doing 4, sometimes you're doing 2, are you doing 1? Does it depend, is there a dose dependency on something?
Typically, for most children, we do 2.
Okay.
So we should try, and then typically it should say, you could repeat it hopefully. And I don't know of any even young baby that I just do 1 puff.
Right.
The ICS for Monterey, there's a lot of, 1 puff at a time, but I'm on the Sample committee and they were trying to say, let's be unified. So even though like some of the, nice, beautiful articles are just going 1 puff at a time for ICS for Monterey, we're like, everything else is 2 puffs. Let's just make it uniform so it's very easy for school nurses and everybody to say that. So most likely for most patients, most children 4 and above, and those are the school age kids, it's always 2 puffs, even for the babies, we do 2 puffs.
Okay. Is there any difference with that with the micrograms? Cause I noticed that too, like I got a 1 puff, but it was more than a 90 microgram dose, like the actual meter dose.
Most of them are the 90 microgram, and then, for albuterol, it is, there's all the 2 puffs, it's typically 2 puffs.
And the other piece of my question was in terms of the age of diagnosis, because I still am hearing that too. The doctor can't diagnose them with asthma until they are such and such years old. Is that something that?
So we can actually diagnose asthma at any age, even infants. So we can diagnose asthma all the way down very, very young, even infancy. The main thing though, it's usually a chronic, condition. So it maybe not be like in a newborn, right? But we definitely could diagnose asthma in infancy. It's not just one thing that we're looking at, symptoms. And also we do know that there are major risk factors for development in asthma. Those are if the parent has a history of asthma, if there's a personal history of eczema of a child, if they have, allergy, like to inhalant allergen. Those are major determinants for the prediction that they'll have asthma, that's a chronic cough. So there are some things that we look at for major determinants. There's minor determinants, like if they have food allergy and things like that. And there's also, on exam, are they responding to treatment? We do have lung function, so GINA and the guideline states that we really need to solidify diagnosis. And the older kids were able to do lung function tests. So we're able to see what is their lung function and do they respond to a fast-acting, bronchodilator. And also, what kind of pattern do they have, and do they have other allergic comorbidities that might make them more likely? So there's no one test for asthma, but oftentimes the gold standard spirometry response to bronchodilator is a very good test for us to see. If they're old enough, they have to be old enough, but you can diagnose young.
Okay, thank you.
I have a couple questions. So first one was, I went to a conference many, many moons ago with a pulmonologist who we were talking about asthma, and we were talking about like not having the inhaler at school. And they said if you're in a bind, you can give a student a carbonated beverage because it works as sips of a carbonated beverage because it works as a bronchodilator.
I haven't heard that, but I agree with you on the caffeine. So the caffeine.
I'm sorry, I meant
have-
caffeine. I said I meant caffeine. Sorry, I said carbonated, but I meant caffeine.
Yeah, so
Caffeinated,
caffeine does,
Caffeine, because it's a bronchodilator.
we do think that it has some effect on the diaphragm. I don't know if we would say to give that if you're just like, don't have it. We do
No, like
use it as
emergent,
a-
yeah, but like they were saying,
I'm not
like-
sure we've ever, I don't know if any of us would say to give it, but it
Yeah, not in
does
severe
have,
distress, but.
So I say call 911.
Yeah, oh yeah, no, we would all do that, but I'm just saying
I
not
don't know if I
distress,
could-
but.
Yeah, I
they
don't
could
know if
use
we've
it
ever
to help
endorsed
them.
that, but it
Okay.
does have a effect on the diaphragm, it's a stimulant, so, but I don't know if we've ever endorsed, so, I'm not sure.
And then the
I'm
second
scared
part
to
was-
endorse and be the one, Dr. Marie said that you should use caffeine, and I don't know.
It was a while ago, it was a long while ago, so I want to ask, but,
Yeah.
and then the second one was, when we're working on our policies right now for our district, the pulmonologist I'm working with is working on adding epinephrine, as, for asthma as well.
Interesting.
So what is your, because I know she said she's given it, how many
7
times?
times.
Yes, for
I've given it
asthma,
7 times
the
for
emergency
asthma.
epinephrine, yes, because if they
didn't
have the
an
stop
inhaler
line.
at school.
Oh.
And they were.
They don't have an inhaler
asthma
for that reason.
exacerbation.
I mean, we definitely know that, epinephrine is a beta agonist, so it can help, but in terms of, that being on part of the asthma action plans, I haven't.
Not on the
covered that.
plan, but like the emergency, like
On
the asthma
emergency-
policy, like.
Yeah,
the
and we actually
emergency
have an
policy.
emergency
Yeah.
plan, as well, and that is not on there. Although, you know, an emergency situation, you know, but I'll have to say, I have not heard that it's part, that we've even put it on. And we do have emergency plans for asthma. I have not heard of the epinephrine. I've had so few of my patients want it there, and we've usually not recommended it. And I know that in third world countries, they may not have all the same medicines that we have. And that was a patient that was like, oh, I was in so-and-so, and they gave me the epinephrine, and it worked, and yeah, it'll work, but, you know, there's so much side effects, and I don't know if us ever wanting to consider that at this time. But yeah, I would give it if there was life-threatening.
Yeah, life-threatening.
Yeah, life-threatening, you could use it, but I don't know if I could endorse it. I don't want to get myself in trouble. Go ahead.
If we don't have a spacer, do you have any suggestions on homemade or holding it farther away from the face or anything like that?
Some people say we have like a cardboard, like toilet paper roll, you know, we possibly, or even like a water bottle, you know, that's a possible way to do it. I think there's some like a way, and if the child is able to, you know, breathe out, empty out their lungs, keep their inhaler just a few, you know, like we say, 2 finger breaths away, spray, and then breathe in. If they're able to have some kind of tube that they could use possibly, but if the tube doesn't have all the, you know, then it may not, it'll be just in the air too.
So they're not supposed to put it in their mouth and go.
Yeah, if they should
it's
probably
supposed to be
just,
two-
yeah,
it's supposed to be
tube,
two
and
finger
then
breaths away,
2
right?
finger breaths, and
Okay.
one at a time, and then
Yes.
breathe in as much as they're able to, but not 2 at a time.
Right.
Because I'll stack the breaths and they won't be able to get the full 2 breaths in.
But if they don't have a spacer, you do have them put it in their mouth?
No, we usually try to, just a little bit
fingers,
away, except for maybe very, very young children, but even then, you're probably getting a lot of medicine in the throat.
Right. Cause like when you see everything, it always shows them putting it in their mouth and doing it like
Yeah.
that. And when we try to, you know, we teach them, no, you're supposed to do 2 finger.
Yeah, and
away,
sometimes some of the
they get very
little ones that
surprised.
they just really can't, that you
Just
might,
wanna make sure.
but we're always trying like, you know, they need a
Yes.
chamber device, cause probably we're losing like about maybe 60 or 80% of the medicine if we do it that way.
I have a question as
Go
far as
ahead.
the air chambers. I've seen those little mini chambers. Is there any difference between the length of the chamber?
So this one, so many of them that usually we like a certain length, is good. And then some of them have, the masks are smaller, so this one is for medium-sized children. And then if they're able to breathe in at one time, then no mask is then recommended.
So those mini ones,
Yeah, usually not as recommended. And then typically I don't see a mask on them either.
they're just great because they fit in the little cabinets.
Oh, that's right. That's right. I think some of maybe the older kids, you know, and it's something is better than nothing, so you'd also say too.
Like the practicality of space and the health office covered.
Okay, yes, that's right.